everyone. Welcome to our first How Do I episode in English. Today we will talk about evaluation and management of AVP deficiency and AVP resistance. It is my great honor to introduce our guest, Professor Mirjam Christ-Crain, a full professor of endocrinology, Chief of Clinic for Endocrinology, Diabetes and Metabolism at University Hospital Basel, and future President of the European Society of Endocrinology. Professor, welcome. It is a privilege to have you here today.
Thank you very much, Mirjana and Carla. It's an honor for me to be here and to talk of one of my favorite topics, AVP deficiency, and also a bit of AVP resistance. Thank you for the invitation.
Thank you for accepting our invitation. So we can begin with first questions. What is the differential diagnosis of polyuria polydipsia syndrome, and what are possible causes of polyuria polydipsia syndrome?
Yeah, thank you, Mirjana. I prepared some slides, so you see here the first two questions. First, what is the differential diagnosis and of polyuria polydipsia syndrome? And as soon as we have excluded osmotic diuresis in a patient with polyuria and polydipsia, which is usually due to diabetes mellitus, we have to differentiate between these three entities, which is arginine vasopressin deficiency, formerly known as central diabetes insipidus, where you have a lack of vasopressin production or secretion from the hypothalamus or posterior pituitary, leading then to polydipsia and polyuria, or arginine vasopressin resistance, also known as nephrogenic diabetes insipidus, where you have renal insensitivity towards the action of vasopressin. And lastly, a primary polydipsia, where there is an excessive thirst leading to consecutive polyuria, but in principle, the vasopressin system is normally regulated. And it's very difficult to do this differentiation, but it is important because treatment is different and the wrong treatment can have dangerous complications, as we will see in the following. But first, what are the causes of these three entities? And for vasopressin deficiency, it's mainly a trauma due to surgery or injury. It can be neoplasia, and an important take-home message here is that a pure pituitary adenoma usually does not induce AVP deficiency, but it needs some hypothalamic involvement, such as craniopharyngioma or a germinoma. It can be vascular, granulomatous, infectious entities, inflammatory or autoimmune in case of hypophysitis, and of course also idiopathic, or it can have genetic causes. And for AVP resistance, the most often seen causes is lithium intake, but also transient AVP resistance due to hypercalcemia or hypokalemia. And also here it can have genetic causes. And with that, I give back to you.
The second question, Professor, is how can we diagnose AVP deficiency, AVP resistance, and primary polydipsia?
Yeah, that's also a very important and I must say quite difficult question. And I would like to first point to baseline measurements, because if we have a patient, we don't want to immediately go towards a stimulation test such as the water deprivation test, but first look at the patient in a baseline level. And here in this study, which we published this year, we looked at baseline sodium levels. So if the patient at baseline has a sodium above 145 millimole per liter, this is actually ruling in AVP deficiency. We only looked at AVP deficiency and primary polydipsia in this study, not at AVP resistance. And this was seen in a development cohort and it confirmed in a validation cohort. And on the other hand, if sodium is low, is below 135 millimole per liter at baseline, this rules out AVP deficiency. So these patients have primary polydipsia. And again, this was confirmed in a validation cohort. And also we looked at copeptin very briefly because I think you know copeptin, but it's the C-terminal peptide of pro vasopressin. And it's in contrast to vasopressin, is easy to measure with a commercially available assay, sandwich immunoassay, and it's much more stable than vasopressin. And you see on the right panel here that there is a quite good correlation between copeptin and vasopressin, which means that if we measure copeptin, we know indirectly about the amount of vasopressin in the circulation. And now that we have copeptin, we can also measure that at baseline. And again, if then the level is above 5.6 picomole per liter, it rules out AVP deficiency. And this is all at baseline, so we don't have to do any stimulation tests. And also, there is not only lab, there is also important clinical questions, such as, does the patient have nicturia more than 3 times per night? Nighttime drinking exceeding 1 liter, a sudden onset of polyuria, polydipsia, or of course the presence of anterior pituitary dysfunction. And I don't go into detail also due to time issues, but if you do a score out of these lab and baseline clinical questions, you can correctly diagnose around 70% of patients. And with that, I would like to show you this algorithm. So if you do a baseline exam with sodium, copeptin, and a clinical score, and if copeptin is very high, I didn't show you these data, but if it's above 21 picomole per liter, it points to vasopressin resistance, nephrogenic diabetes insipidus. If it's above 5.6 and also you have a clear clinical score, it is primary polydipsia. And the difficult question is what to do with these patients with unclear clinical symptoms and a baseline copeptin below 5.6. And here we have to do a stimulation test. And without now showing the detailed data, but the best data are available for the hypertonic saline test. It needs regularly control of sodium levels. And of course, you should not have contraindications for the test. We have to stimulate sodium to 149 millimole per liter or higher. And then with this cutoff of 4.9 picomole per liter, we can differentiate between vasopressin deficiency and primary polydipsia. On the other hand, if we do not have the possibility to control sodium or we have contraindications, we can do the arginine test. It's important to note that the arginine test is inferior than the hypertonic saline test, but with these two cutoffs of below 3 and above 5.2 picomole per liter, we can diagnose around 50% of patients. Below 3 is vasopressin deficiency and above 5.2 is primary polydipsia. And of course, and I don't know, I think you have copeptin, but if not, we still can do the water deprivation test. So I give back to you.
So what are the recommended treatment options for AVP deficiency and AVP resistance? And what are the potential side effects of these treatments used for this condition?
Yeah, of course, a very important clinical question. So for AVP deficiency, it's quite straightforward. And the treatment of choice is exogenous desmopressin, which we have as tablets, as nasal spray, or as melt. And usually we start at bedtime, so the patients do not have symptoms during the night. And if needed, we add a morning dose. And you see in this table the approximate starting dose and also equivalent dose if you want to change from one application to the other. It's important to know that the most common side effect of desmopressin is hyponatremia, is dilutional hyponatremia. And you see the risk of hyponatremia is around 27% for mild and 15% for more profound hyponatremia. So that's quite common. And importantly, therefore, we should instruct the patients when initially prescribing desmopressin about the desmopressin escape method, which means that they delay a tablet with every dose or once daily, once per week, several times per week. That depends a bit on how frequent they experience hyponatremia until they experience aquaresis and feel thirsty. And usually in the beginning, I tell the patients that they should do that at least once weekly so that the hyponatremia frequency is lowered. And if they have very frequent hyponatremia, of course, they should do it with every dose. Then the most common reason for AVP resistance is as mentioned, lithium. So this is an algorithm for lithium-induced AVP resistance. The first important question is, can lithium be discontinued? And this, of course, has to be discussed with the psychiatrist. If no, then the first step is a dietitian referral with a low sodium diet and low protein diet, which leads to less osmotic diuresis and less urine output. We have to monitor lithium levels because every treatment of AVP resistance, and that's important to know, can lead to an increase in lithium levels. So therefore, reassess in 4 weeks, and then if symptomatic polyuria persists, we can start with amyloid, again, monitor lithium levels and reassess. And again, if symptomatic polyuria persists, we can add hydrochlorothiazide. And lastly, we have also the option of high-dose desmopressin because sometimes it's only a partial resistance, or also non-steroidal antirheumatics. And if lithium can be discontinued, we should monitor whether the polyuria persists. And if it persists, only then, after 3 to 6 months, we switch to the left side. Outside of lithium, the treatment of AVP resistance is quite similar. It is the treatment of the underlying disorders, of course, a low sodium, low protein diet, thiazide diuretics, non-steroidal antirheumatics, and a high dose of desmopressin. And with that, I'm at the end.
Thank you, Professor. That would be all our questions. Thank you for this great lecture. It was a pleasure having you here.
Thank you very much for the invitation.
Thank you. Bye.
Thank you. Bye.
Bye.